Hello and welcome to this evening's webinar for doctors returning to work during the pandemic. I am Dr. Kirsty Smith. It is a pleasure to welcome Dr. Rebecca Shakir as our speaker this evening. Dr. Shakir is a clinical oncology registrar and has been working as a clinical research fellow at the University of Oxford. Tonight she will be speaking to us about oncological emergencies. Thank you so much for joining us this evening. Sorry, I'll just need to unmute you. I think your mute's been on.
Perfect. So hopefully you can hear me now.
Yes, it's perfect.
Brilliant. Great. Thanks everyone for joining us on what's a very nice and sunny evening. And thanks Kirsty for organising. So what I'm going to do is talk to you for the next sort of 35-40 minutes about oncological emergencies, a bit of an update, and then COVID and cancer. Okay, so what we're going to be covering is just very quickly a general approach to the patient with cancer, and then cover some of the oncological emergencies that you'll tend to be very common in oncology and you see quite often as general medics, and then a brief bit about COVID-19 and cancer, which obviously has hit the news a lot in the last week or so. So patients with cancer are very much the same as any other patient. As you know, 1 in 2 patients gets cancer, or 1 in 2 people in the UK gets cancer, so these patients are common. And really, you approach them in a very similar way to all patients without cancer, but there's a few things that are really important to consider and that are very helpful for us to know as oncology registrars if you ever need to phone us about these patients. First is the stage of disease, and in particular, are we treating them with curative intent or with metastatic intent? So, palliative intent if they got metastatic disease, and also how are they responding to their current treatment? Obviously, those 2 things make a huge difference in terms of what we're likely to do if they've got a reversible deterioration or an irreversible deterioration. So it's quite important to get that out from the history quite early on. Also a sort of idea of an overall prognosis. Are we talking days, weeks, months? Because again, that will make a difference into what you decide to do. And what's absolutely critical when you're seeing a patient with cancer is what do they want and what do their family want? Some people will not want to stay in hospital for IV antibiotics, even if you think there's a possible chance that that might make them better. They may just want to take their chances and go home on orals, especially at the moment. And so it's really important to understand that and take that from the beginning of them getting into hospital so that you can shape a management that works for them. So why do these patients come into hospital? Why do they come into A&E, and why do you see them as general medics? So the number 1 kind of oncological emergency is febrile neutropenia, or what used to be called neutropenic sepsis. And this really can affect anybody with cancer, especially if you've had chemotherapy in the last 6 weeks, but also patients who've had stem cell transplants and patients with myelodysplastic syndrome who may persistently be neutropenic despite not being on treatment. The kind of definition of clinical features is any temperature above 37.5, tachycardic, tachypneic, rigors or sweats. These are all things that we know, but the thing that gets missed is the patient who is afebrile but just presents with diarrhea. And that's a really critical one not to miss. So if you have a patient just with profuse diarrhea, just think, could they be neutropenic, and could this be neutropenic sepsis without a temperature? Obviously, we know the signs of sepsis, hypotension and hypoperfusion, therefore resulting in lactic acidosis, oliguria or confusion. So the official definition is anybody with a neutrophil count of less than 0.5 with their temperature, but also if it's less than 1 and expected to fall rapidly. And the nadir of neutrophils is about 7 to 10 days after chemo. So somebody who's kind of day 5 and their neutrophils are 1 is more concerning to me of someone who's day 11 and neutrophils of 1, because they're likely to be going up rather than down. But the most important thing is that you don't wait to give antibiotics until you know what their neutrophil count is. If you suspect that they might have neutropenic sepsis or febrile neutropenia, just give them some antibiotics and then get a white cell count, unless you're lucky enough to have a point of care one. So the management it's really time critical. Okay, so these patients need to be seen within 30 minutes, have a cannula, check they're not allergic to any antibiotics, and give them some antibiotics within 60 minutes. So it's really a very brief history, investigations, sent off in terms of blood cultures and bloods, examine for a focus of infection, but most importantly, get those antibiotics with them within 60 minutes. Again, that's not prescribed on the drug chart within 60 minutes, it's actually given. Okay, and it's important to just make sure that the nurses are available and know that they need to give them. So in our trust and most places in the country, the first line treatment is tazocin. But the people to just watch out are patients on high dose methotrexate. In our trust, they will flag up that they're allergic to penicillin. It's not because of that, it's because penicillin affects the renal excretion of methotrexate and can give them much worse methotrexate toxicity if they get penicillins. So they must be treated with meropenem in our trust. It may be different in yours, but not penicillins. Most of the patients are pretty clued up about that and will tell you that they can't get penicillins, but it's an important thing to ask in the history. And then we give ciprofloxacin and vancomycin if they have a severe penicillin allergy. If you know that they're MRSA positive or their line is clearly infected, it's not unreasonable to give vancomycin. And the patients with diarrhea or perianal sepsis, or if they've clearly got a dental infection, adding some metronidazole orally is good as well. And most people ask, is it possible to use the line? And if they've got a PICC line, unless it looks clearly infected, as in there's pus coming out of it, it's absolutely fine to use their PICC line to give the antibiotics. Good to get some peripheral cultures as well as PICC cultures. If they tend to have a spike every time that their line is used to flush or give antibiotics, that's an indication that maybe it is colonised or infected, but it's not unreasonable to use it. Unless they're really unwell after you give the antibiotics through it. The people who end up not getting adequate treatment and therefore becoming unwell and sometimes unfortunately dying are patients who present afebrile. So if patients are profoundly neutropenic, they often just don't mount that immune response, and so they are afebrile when they come in, so they don't get flagged as being febrile neutropenic. So just be careful of the patient who's sick but doesn't have a temperature. You're unlikely to be criticised for giving a dose of tazocin and just working out what's going on, but they can get sick very quickly if you don't. And then I've said it before, but the patients with diarrhea who don't have temperatures, again, just think, could this be a kind of neutropenic affection? So GCSF, this confuses people because some trusts have different policies on this. So the evidence behind GCSF is that it can reduce the duration of neutropenia, but there's no evidence that it reduces morbidity or mortality for patients coming in with febrile neutropenia. So you can consider using it, and generally we would say phone us, don't just start it. But if somebody's got an absolute neutrophil count of less than 0.1, or they've got very protracted neutropenia, more than 5 or 7 days, and it doesn't seem to be improving, or they've got an invasive fungal infection, or possibly pneumonia, or they're really sick with multi-organ dysfunction, sometimes we give it. And if we do give it, we wait until the neutrophil count, we give it until the neutrophil count is more than 0.5 for at least 2 days, or more than 1 for a day. It's subcutaneous, and we give it at 6 p.m. And so then you see the next day the effect of it overnight. Now, GCSF as prophylaxis we do use more commonly than using it as a treatment. So chemotherapies that have more than 20% risk of developing febrile neutropenia, we would give routinely GCSF to the patients. So most of the breast cancer patients will have GCSF with their cycles of chemotherapy. Sometimes we give it with lower risk chemotherapy regimes if there's patient-related risk factors, such as COPD and recurrent lung infections. We may give them GCSF just because we know that they're susceptible to getting pneumonias during chemo otherwise. And then sometimes we give it as secondary prevention, so where we know that somebody is getting febrile neutropenia all the time and we're giving them curative chemotherapy, so we don't really want to dose reduce or delay, then we'll consider giving GCSF. And sometimes we give it with palliative chemotherapy, but you've got to be careful about the risk benefit there. And if somebody's recurrently getting febrile neutropenia, which has an associated mortality with it, you've got to question, are you doing the right thing? And should we really dose reduce the chemo or even stop? Now, if somebody comes in on GCSF and they've got febrile neutropenia, just keep on going with the GCSF. So carry on. They're normally on it for 5 or 7 days max, and just keep it going, but just make sure that their white cell count doesn't get above 50. And we are having a bit of a lower threshold for using prophylactic GCSF at the moment because we're obviously concerned about our patients ending up in hospital, but also being more susceptible to infection during the current pandemic. So you may see more patients on GCSF at the moment. So what's new, because that's all very similar to what you've all learned at medical school, so what's kind of new in the last couple of years? So we are now discharging people with febrile neutropenia, which kind of a couple of years ago was absolutely never done. But we kind of developed this score internationally, which helps us risk stratify patients with low risk febrile neutropenia. So essentially people who are well but febrile and neutropenic. We use this SINSI score, which I'm not going to go through, but is there for reference, to classify them into either low, moderate or high risk, where we know that if they're in a low risk group, their risk of complications is really extremely low. And then in Oxford, if they're over 18, they're normally getting their chemotherapy as an outpatient, they are reliable, they'll phone us, they can come up and down to triage, and they've got a SINSI score of 0, we're discharging them with oral antibiotics. They do get observed for 4 hours before, just to make sure they're not going to deteriorate, and they come back the day after. And then we contact them every day for the next few days, just to check that they're okay and they're not deteriorating at home. So that's kind of the new thing for febrile neutropenia. So moving on to metastatic cord compression, another very common complication of cancer and a kind of oncological emergency that I'm sure you will all see, and scientifically proven on research, randomized control, not randomized controlled trials, but scientifically proven on papers, observational studies, that it happens more often on a Friday afternoon. I think it's because we tend to investigate patients more on a Friday because we want to get their symptoms sorted before the weekend, but inevitably we have a bit of a flurry on a Friday afternoon of cord compression referrals. So cord compression happens either because you've got a tumour mass or the bone itself compressing the dural sac and its contents, and it can either affect the spinal cord or the nerve roots. We would treat nerve root compression or cauda equina compression in exactly the same way, exactly the same level of emergency as a true cord compression. And there's about 4,000 cases a year in the UK. Won't surprise you to know that prostate and breast cancer are commonly cause cord compression. These are common cancers, unfortunately, which affect the bones, but lung cancer quite often causes it as well, and GI cancers in this cohort from Aberdeen were reasonably common. The kind of standard you used to hear was renal as well. We really don't see renal cancers causing cord compression that often anymore. We've got a whole load of new drugs that control renal cancer pretty well. So that's sort of dropped off our workload, and we do see mainly prostate and breast and lung cancer, unfortunately. The thing that you've really got to suspect cord compression with is pain. So 90 to 95% of people present with severe, intractable, progressive back pain. By the time they're getting neurological symptoms, they're actually pretty late down the line. So it's the pain that is the thing that should flag up to begin with, that there's something going on. It's often a sort of nerve root pain, burning, numbness, shooting. But before that, it's a pain in the back, can be worse on motion, but it's one of those ones that tends to wake people from sleep as it gets worse, and it just doesn't go, and it kind of builds in severity. But it doesn't hugely localise to the site of compression particularly well. Firstly, these patients often have widespread metastatic disease. They've often got multiple vertebrae involved. But even then, the body doesn't localise vertebral pain particularly well. So it won't necessarily be a one site thing. Obviously, by the time they've got difficulty walking, you're pretty late down the line, and reduced power and altered sensation in the limbs. And again, they can get bowel and bladder disturbance, but again, it's pretty late down the line. So bowel incontinence or urinary retention. The thing to do if you suspect that these patients have got cord compression is give them some dexamethasone. It's 16 milligrams, give them straight away oral. There's no evidence that it's any more beneficial to give IV dexamethasone unless somebody can't tolerate it orally. The bioavailability is pretty much the same, so oral is absolutely fine. And subsequently they get 8 milligrams twice a day, but please don't give it at 6 in the morning or 8 in the morning and 8 at night, because they will not sleep. So the last dose by 2 p.m. at latest. I prescribe it for midday, because then even if the nurses are busy and delayed, they don't get it too late in the afternoon. And it's important to monitor BMs. Obviously, if they're diabetic, you need to monitor them really closely, but even if they're not, at least a once a day blood sugar, because 16 milligrams of dex is a pretty high dose, and not infrequently we see patients getting quite high sugars even if they don't have a history of diabetes. They then need a whole spine MRI, and don't let anybody say you don't need a whole spine MRI. You absolutely do. So these patients might have widespread disease, they can have multi-level cord compression, and it's really important that we don't miss multi-level, and we don't miss the actual cord compression. Even if you are convinced they have got a sensory level, or they've got neurological motor symptoms that absolutely fit with one spinal level, they still need a whole spine MRI. I personally have never seen a proper sensory level, and you just get very vague symptoms. So they do need a whole spine MRI. If the radiologists try and convince you that they only need a thoracic, you're just wasting time, because they're then going to need a lumbar and sacral to make sure they haven't got anything elsewhere. So just please get a whole spine MRI. And make sure they've got adequate analgesia before they go down. That scan takes about an hour. If they've got horrible back pain, it's really uncomfortable lying on the carbon fibre couch. And it's really, really frustrating for the patient and for everyone involved if they've gone down there and they can't tolerate the scan. So, but do tell the radiologist where you think the level might be in terms of their symptoms, because they will take axials at the level of potential cord compression. If you don't know, it's fine. Just write the neurology on. The radiographers are very good, and they will look and they'll do axials where they can see a problem. Phone us straight away, even before they've had the scan. In Oxford, we have a fantastic electronic system called ORS, and places are adopting that. We will liaise with the spinal surgeons, and we might organise a CT, which the spinal surgeons often want to guide their surgical management. But these patients need definitive treatment within 24 hours. Hopefully they've already got histological confirmation, otherwise it becomes slightly tricky. But we still need to treat them within 24 hours wherever we can. So if they've got histological confirmation, then that's fine, we just go ahead and treat. If they don't, if their PSA is over 100, we accept that that's prostate cancer. Anybody else needs a biopsy, and ideally we just want to show that it's cancer before we treat. What we do not want to do is irradiate spinal TB. We don't want to irradiate an epidural abscess, and these are things that can masquerade as being metastatic cord compression. So we will help if patients need a histological confirmation before. Just something to mention here is, if this patient might have lymphoma and it's a first diagnosis, just be careful about giving the steroids before you've had a biopsy. 16 milligrams of dex will melt away most lymphomas within a few hours. So it's the only situation where I wouldn't give the steroids just straight away. If it's somebody who has got lumps, or there's just something that makes you think they're the right age group, they've got no other symptoms, and maybe this could be lymphoma, just have a think and try and get an urgent scan before you give the steroids. But talk to us about these in the haematologists. I have only once or twice seen people who have got a very sudden onset of weakness. It's not usual if it's just bone disease. So somebody who says, I could walk and then I suddenly couldn't, is typically an infarction of the cord, where one of the spinal arteries has just been compressed and infarcted the cord, but it's not that usual. We will assess, based on imaging, something called the spinal instability neoplastic score. Now, some people would advocate putting everybody on bed rest until you have a scan. And you've got to be careful about it. There are risks of being on flat bed rest as well. And if somebody's been walking around at home for weeks, you're unlikely to make it significantly worse in a few hours waiting for a scan, but just be sensible. The big kind of signs of instability is if their pain is mechanical. So if it gets worse on movement, that's a mechanical pain that can suggest instability, and you're probably safer keeping people on bed rest for that. But if it's not, it's probably reasonable to keep them up and about, just very cautiously, and not if they're at risk of falls. Okay, but we will then assess their stability once we have a scan, and that'll help guide us on their treatment. The things to think of while we're waiting for scan and waiting for definitive treatment is make sure that they continue to be hydrated, they've got nutrition, possibly catheterize them if they're on bed rest. Don't forget venous thromboembolic prophylaxis. These patients with cancer, they're at much higher risk of clot. Be careful of their pressure areas. Please give them lots of analgesia and just watch their bowels. And as soon as a SIN score indicates that it's safe, get them up and about with the physios if necessary. And the majority of them benefit from steroids within 48 hours for the pain and edema, so get those started. Our sort of treatment is radiotherapy, but actually the best treatment in terms of functional outcome in the long term is decompressive surgical resection, which we are trying to carry on doing in the current pandemic as much as we can where it's safe, in COVID negative sites, often at the moment in private hospitals we're using their kind of theatres to do this sort of work. But if you can, surgery is the best option for these patients. If not, we give radiotherapy, and very occasionally if you've got something like a small cell lung cancer or a lymphoma which respond extremely quickly to chemotherapy, you can use chemotherapy to treat cord compression. So people who we definitely want to go for surgery are those with a single site of cord compression. If they've not got known histology and there's nothing else, surgery has the benefit of treating their cord compression but also getting us good pathology that we can send off. If they've got bone compression or vertebral collapse, surgery is better at stabilising that than us, and so definitely if they've got spinal instability, surgery is the best option. Otherwise they end up having to have radiotherapy and be in a brace, often long-term, months if not forever. And obviously if somebody's progressed after radiotherapy, that's an indication for surgery. The majority of patients, however, do come for radiotherapy because their prognosis is poor and it's not felt that their recovery from surgery, the time that would take, is in their benefit. Commonly the treatment we give is 20 gray and 5 fractions. If somebody's got a longer prognosis, occasionally we give 30 gray and 10, although we're not doing that so much nowadays. And then we have been doing an 8 gray single fraction if somebody's got a poorer performance status, very poor prognosis, or their ambulatory status is very poor. So if somebody already is really not able to walk from the level of weakness because their cord compression has progressed that far, then probably just a single fraction for pain is beneficial. And what radiotherapy tends to do is maintain the current ambulatory status. It's reasonably rare that people recover power if they've already lost power. This is a radiotherapy machine, a LINAC, a linear accelerator. So the patient comes and lies on one of these couches, and it takes about 20 minutes by the time we set them up. And so just be aware of that. If people are coming down from your ward and having radiotherapy, they really need to have good analgesia to cope with that. If they're having their neck treated, they'll be treated in a mask like this, which clips them onto the bed. And the LINAC itself rotates around the patient to treat them. Most patients will typically be treated with one field from the back, one field from the front, and again, it takes about 5-10 minutes maximum, usually. And radiotherapy is just high energy x-rays, is essentially what that LINAC produces. But the thing about cord compression is that it's very poor prognosis. Median survivals, only 3 to 6 months, only 30% of people alive at a year, unfortunately. And the thing that's most important in terms of their long-term functional outcome is what ambulatory status they had before treatment. So that's why getting them some definitive treatment early is the most important thing for them. And if possible, surgery is the best option, followed by radiotherapy to consolidate. So what's new in cord compression? So just published is a trial called the SCORAD trial that was a multi-centre RCT, mainly run in the UK and Australia. About 700 patients who had a prognosis of more than 8 weeks and biopsy-proven cancer or prostate cancer. And they looked at the ambulatory status at 8 weeks. Unfortunately, only 50% of people within that trial were accessible. 37% of them died before 8 weeks, unfortunately, despite oncologists assessing at the entry to the trial that they had a prognosis beyond 8 weeks, which just highlights how difficult prognosticating for these patients it is. The median survival time was really quite poor, 12 to 13 weeks, unfortunately. But the conclusion was that a single fraction is not non-inferior to 5 fractions, but the confidence intervals significantly overlapped. And so the conclusion from the trial was that a single fraction was probably a reasonable option in patients with a poor prognosis. Maybe all patients, because maybe all patients with metastatic cord compression have a poor prognosis, but I think there's some nuances in that. Patients with metastatic breast cancer with bone-only disease can live for years. So it's important to just, take that in the context of that patient. But what we are doing given this evidence and the current pandemic, while we're trying to keep cancer patients out of hospital, is that many centres have adopted the 8-grade single fraction as standard during the current pandemic, but there are still some nuances to that. So coming on to immunotherapy, which is a big new thing in the last few years, wasn't routinely a treatment for cancer when I started being a registrar in 2013, but we now routinely used for many tumour sites. So these are agents which aim to reintroduce the cancer to the immune system. So people think that cancer is a bit like a failure of the immune system. So it's the immune system not picking up cells that are abnormal, that should be recognised as foreign and got rid of. The immune system has failed to do that. And what these drugs are doing is reteaching the immune system that these cancers are abnormal. So the three drugs that first came out were Ipi, which is a CTLA-4 monoclonal antibody first used to treat melanoma, which used to have a dismal prognosis, no real systemic treatment options that worked. And now we see patients who have 3 to 4 years of response on ipilimumab and going on to be durable responses, treating melanoma as a long-term disease, which completely has revolutionised it. So that's been joined by Pembro and Nivo, which are monoclonal antibodies to the PD-1 receptor, and again treat melanoma, but pembrolizumab is also used for lung, prostate and lymphoma. Newer drugs are atezolizumab, avelumab and durvalumab, which get increasingly difficult to say. So we call them Durva, and we don't use these two so much. These have started to be used for urothelial cancer, and particularly lung cancer is a group of patients who are able to benefit from these drugs. And avelumab is used for a type of skin cancer called a Merkel cell carcinoma, which previously didn't have many treatment options. The trouble with these drugs is that they sometimes have these very odd reactions. They are immune-mediated adverse reactions. They're very different to the kind of chemotherapy-related side effects that we're used to in terms of, hair loss, GI side effects, and depletion of your bone marrow. You don't really get that so much. You're getting also almost like an autoimmune sort of diseases. They're not dose-related. They can happen straight away, or they can happen on cycle 15 when you think somebody would have got away with it. So they're odd, but essentially they can affect any organ system. They commonly can get, unfortunately, a colitis. Their endocrine organs can all be affected. They can get a pneumonitis, a nephritis, hepatitis, a uveitis, meningitis, odd neuropathies, and bad sort of pruritus and rash as well. This is just showing that really you can get any symptom you can think of affecting any body system can cause immunotherapy can cause a toxicity in it. The critical thing is that we recognise and treat these toxicities early to stop patients dying and to stop morbidity. In the trials, before we really understood this, not an insubstantial proportion of patients lost their colons from a colitis that was refractory to medical treatment. So we try and treat and recognise very early. The mainstay of treatment is steroids, basically to suppress T-cell activation. So you're just trying to do exactly the opposite of what the immunotherapy was doing. because it can affect their pituitary, it's really quite important to try and get a baseline cortisol before you start the steroids. Just get some blood sent off for that, so that you can go back later and work out whether they had a hypopituitary as well. Keep a good eye on the BMs, and these patients, once they're on steroids, tend to need to be on steroids for quite a few months. So it's good to start calcium and vitamin D early so that we don't really ruin their bones during that time. And given that they're going to be on for a reasonable amount of time, we often give PCP prophylaxis as well. Like I said, these toxicities can start week to months following treatment, which seems odd. So just because somebody's a few months into their treatment doesn't mean they can't get them. The thing is to do is speak to us closely, and also we speak very closely to our medical colleagues, so the liver team for the hepatitis, the respiratory guys, our endocrinology colleagues, and we're getting good sort of multidisciplinary teams in how to manage these patients. We now know that quite quickly, if steroids aren't working, we need to use other immunosuppressants, MMF or infliximab. These are drugs that we haven't typically given as oncologists, that we're getting quite used to having to give for patients where steroids aren't working quickly. And the thing just to let patients know is that there is good evidence now that their outcome from their cancer is not affected by the use of immunosuppression. So there was a concern initially that you were basically reversing any beneficial effects of immunotherapy by giving steroids or immune suppression, and that is not the case, which is good. Now, these are just really in for reference, but most cancer centres will now have clear stepwise treatments of how you manage these toxicities, and by our grade on CTCAE grading, we can work out what's the best treatment. So if it's pretty mild, you can just still continue therapy and keep a close eye. If it's getting slightly more severe, then you're starting oral steroids, and people who come in where it's severe, getting IV methylpred straight away. And if it's not settling within 3 to 5 days, probably a bit earlier, then we're considering infliximab. And if that doesn't settle things within a few days, then they go to colectomy, unfortunately. Hepatitis, again, we have very similar guidelines for. We know that MMF, mycophenolate mofetil, or tacrolimus is needed in some severe cases. And the endocrinopathies, some patients do unfortunately end up on maintenance hydrocortisone. You can get a DKA in patients who weren't diabetic prior to this. They can get a bad hypothyroidism, and the one to just watch out for is they can get an acute hypophysitis. The other sort of new immunotherapy type drug that you might have heard of is something called CAR T cells. Now, this is mainly only done in a few centres across the UK at the moment, but these are T cells taken from an individual patient, sent off to a lab and genetically engineered to produce an artificial T cell receptor that can target a specific protein on their cancer. And these are used for lymphomas and leukemias at the moment. So T cells are harvested, genetically altered, you infuse those back into the patients. They're usually autologous at the moment. You can give allogeneic ones as well. They bind to the target, so if it's antigen proliferate, it becomes cytotoxic and kill the cancer cells. So the ones that are available at the moment are against CD19, so B cell cancers, and there's some completely impronounceable drugs which are treating either ALL or diffuse large B cell lymphoma. Now, I'm going to very, very quickly go over a couple of things which used to kind of be classified as oncological emergencies, which you just don't really see that much anymore. So SVC obstruction used to be mainly seen with advanced lung cancers, but also tumours affecting the mediastinum, so lymphoma, thyroid cancer, thymomas or teratomas. You can also get it from thrombosis from a PICC line. So it's the classical things that we'll have learned in medical school: puffy head, neck or one arms, eyes that are very puffy, worse in the morning, or a kind of tightness in the head when they bend forwards, but also shortness of breath, chest pain, and you can see some distended chest wall veins if it's been there for a reasonable amount of time. We investigate with chest x-ray, CT. If you're thinking thrombosis, a Doppler ultrasound or a CT is good. Patients are symptomatically much better if you sit them up, give them oxygen, and we do need a histological diagnosis if they haven't already got one. You can give some steroids, so good dose of steroids if they need it. And then if it's caused by a small cell cancer or a lymphoma, we treat with chemotherapy. But most patients, it's with a lung cancer that often doesn't respond very quickly to chemotherapy, so they will get a stent. And the radiologists very kindly do those for us. And obviously if they've got a thrombosis, then we anticoagulate them. We often then give radiotherapy following a stent if the radiologists have managed to get one in. Hypercalcemia is not uncommon, but actually usually against what people think, is more often caused by a PTH-related peptide, which is released by the cancer rather than bone metastases themselves. We all know the symptoms: nausea, thirst, polyuria, constipation and confusion, and important to check, obviously, corrected calcium and renal function. What's really important is to rehydrate them, and often if the calcium's up to 3, then rehydrating them alone will work. If your calcium's above 3, really try to give them sort of 3 to 6 litres of fluids within 24 hours, as long as they've not got any heart issues, obviously. And then you can give a bisphosphonate. Renal impairment's a relative contraindication, which is why we really try to hydrate them before, and we use zoledronic acid. You've just got to be careful because sometimes they can get a refractory hypocalcemia, so just monitor for that. It doesn't fall quickly, so we often don't get these patients' calcium back to normal before we're discharging them. So it's reasonable, as long as it's not continuing to go up and they're symptomatically better, that they can go home with a community check of their calcium, and we can consider a repeat dose if it's still raised after at least a week, but we can organise that. We don't really give diuretics. There used to be a vogue of giving frusemide, but we're not tending to give that now. It's really important to obviously stop any calcium that they're taking, but also thiazide diuretics, lithium or ranitidine that can all cause hypercalcemia. Mobilising them helps. So often you can actually sometimes see the calcium go up because you're sitting them in a bed in hospital. Mobilising and muscle action reduces calcium, so try to get them walking around the ward. We have had a few patients who are so agitated and psychologically distressed by their high calcium that they will not sit and have a cannula. They pull it out or you can't get one in. So salmon calcitonin is really useful in that situation. It lowers the level within hours, so it just gets them back to normal, and then you can treat them properly with a bisphosphonate and fluids once it's come down enough for them to no longer have the psychological effects of the high calcium. But you mustn't just give that and then let them go home, because it bounces back within a couple of days. In the longer term, you want to treat their cancer to try and keep their calcium down, or we do have some people who we give as an outpatient regular zoledronic acid to keep the levels down. So just coming to the end, I wanted to give you a bit of a kind of update about where we are with COVID-19 and cancer. Obviously it's all over the news, so it's useful to kind of know what's out there about this. So this is what we know at the moment. We think that cancer patients have worse outcomes if they develop coronavirus. So that's based on data from China, which suggested that cancer patients had about a 5 times higher rate of either ending up ventilated or dead from coronavirus. And that was modelled based on a couple of kind of case series. Imperial, Matt Williams modelled what could happen to our cancer population if they followed a similar kind of outcome to the patients in Italy and the patients in China. But we know even if patients don't get coronavirus, there have been significant impacts on the cancer treatment that we're giving. And we're also concerned that patients aren't seeking medical attention for the early signs or symptoms of cancer. So this was Matt Williams's paper from Imperial, looking at trying to estimate the risks in our adult chemotherapy patients, and showing that the case fatality rate of COVID-19 goes up with age, which we know, but actually if you add an excess case fatality rate because of cancer or chemotherapy, it goes up massively, especially in these older age groups. And the dotted lines are kind of, if you're thinking that your chemotherapy is giving a 3% survival benefit, 5% survival benefit, a 10% survival benefit, that actually, you know, as soon as you're over 50, probably the risks of chemotherapy in the current pandemic are less than the benefits. But this is all modelled on data from a reasonably small number of patients. So what we've started in the UK, and what I think is fantastic about the UK oncological community and working in the NHS, is that we've said, well, okay, that's modelling, but what we want to know is what is actually happening to our cancer patients who get coronavirus. And this is data that came out yesterday, unpublished, but by this fantastic UK Coronavirus Cancer Monitoring Project, which has been set up in the last few weeks to prospectively record the outcomes of every patient with cancer who gets coronavirus across the UK. So they have published data now on 606 patients, starting at the beginning of March up until last week. This is about 57% are male, and yeah, 42% female, and you can see that there's kind of the incidence has sort of followed the incidence in the UK. Of the patients that we've got data on so far, the majority have got either GI cancers or lymphoid or hematological cancers. And breast cancer is relatively less compared to the amount of patients that we see with breast cancer. And I guess, again, prostate cancer right down here. So our two commonest cancers are less affected, but these patients do tend to be more well in themselves, the breast cancer population often a bit younger. We're also seeing that they have got comorbidities, so commonly hypertension, some cardiovascular diseases. About 25% of them don't have any comorbidities. So the majority of these patients who are getting affected are patients with comorbidities and cancer. The majority, 55%, are patients with metastatic cancer, but about 22% with localised tumour or a locally advanced tumour. So that's what we're seeing there. And thankfully, the majority, just over half, are getting mild coronavirus, but you know, a quarter each are getting, unfortunately, severe and critical coronavirus. Pleasingly and happily, about 57% of people have been discharged home or were treated at home, but about 30%, 29% have died of coronavirus. And that's sort of plateaued out to those levels in the last few weeks. This is quite interesting. So people who've had chemotherapy within 4 weeks, from the modelling, would have suggested that these patients were going to do much, much worse than people who hadn't had who hadn't had chemotherapy within the last 4 weeks, and it doesn't look like that at the moment. So actually, a higher proportion of those who've had chemotherapy within 4 weeks have been discharged and gone home. Obviously, the thing to be clear about is that patients having chemotherapy at the current time are the young and fit ones. The people not having chemotherapy are older with lots of comorbidities. So there's an awful lot of confounders in this. But it doesn't look like chemotherapy on its own is hugely making outcomes much worse compared to everybody else. What the NHS England guidelines have said to us is that the patients at risk, from what we know from Italy and China, are people on active chemotherapy, particularly patients with lung cancer having radical radiotherapy, have done really badly in other countries. Hematological cancers that we saw, cancers of the bone marrow, are being affected badly. Also, patients on immunotherapy and antibody treatment and targeted cancer treatments are being affected, as well as chemotherapy. And people who've had stem cell transplants, and in particular people over the age of 60 with other comorbidities are at risk. So what are we doing? So we have tried for the last month or so, or longer, to just do telemed clinics. So trying to stop routinely bringing people into hospital where they're probably at increased risk. We're not having visitors, we're not having people accompanying patients for treatment, and you can't underestimate the psychological effect that that is having on our patients, that we must not forget. And we've kind of looked at the risk benefit of various treatments and thought, actually, are we doing more harm by doing elective cancer surgery, adjuvant chemotherapy, and some radiotherapy? So what the NHS England recommendations were that we consider non-surgical treatment wherever possible, and some of that is because we need to protect our ITUs, we need to protect our ventilators, and we need to protect our anaesthetists and not use them for routine work. Trying to change IV cancer therapy to subcut or oral that people can have at home, shorter regimes, increasing the duration between treatments, deferring some treatments, trying to locally dispense or home deliver oral medications, use more GCSF, consider treatment breaks altogether if we think that the risk is high, and use the most hypofractionated radiotherapy, so the fewer number of visits that we possibly can. And some of the things that we've implemented in the UK are these. And the great thing about working in the UK is that these have all been decided by UK consensus. So this is not individual centres making up their own guidelines. We have all sat down with our colleges and worked out what should we do, what is the best thing to do for our cancer patients at the moment. We're doing less pancreatic surgery. We're using a lot more radiotherapy to treat localised pancreatic cancer. Adjuvant breast chemotherapy, where we used to use between a sort of 5 and 7% survival benefit, we would offer adjuvant chemotherapy. We're thinking, well, actually, maybe we should say, actually, let's just offer it to people with over a 10% survival benefit. We're thinking about that. We're treating breast patients with radiotherapy over 5 days instead of 15. And our low-risk neutropenia accepting patients are being assessed by phone, and we're being able to deliver them oral antibiotics to home rather than bringing them into hospital for assessment. And it's important to think as well about the longer lasting impact. So the worry is that cancer patients are going to have an increased peak of mortality at the moment from coronavirus, but there's going to be a delayed increased peak of mortality down the line when the impact of delayed treatment or less intense treatment happens. And that's the worry, and that's what's been picked up by the papers. And also the fact that our cancer referrals are down about 80% compared to a couple of months ago, and this cancer is still happening, so we need to, as much as possible, open our doors to investigate and treat patients early. Otherwise, we're going to have a huge problem with more advanced cancer in the next few months. What our responsibility as healthcare professionals is acknowledge that this is a really difficult time for patients with cancer. It's a difficult time for everyone, but it's particularly difficult for patients with cancer. We do need to encourage them to keep themselves safe and isolate or social distancing, but we need to acknowledge it as oncologists that we're having very difficult discussions, we're changing treatments, there may be delays, and we need to be open and explain that to patients and have an open dialogue about what decisions we're making with them rather than about them. It's important that we do keep cancer treatments a priority, and we're lucky in Oxford at having a split site where we can try and keep the cancer centre a COVID negative site, and places that have that opportunity is a great way to keep cancer patients relatively safe by keeping them in a sort of a hospital that isn't exposed at the high levels. And we need to try and give evidence-based advice rather than kind of newspaper-based advice, and just be really clear on what decisions we're making and why, and make sure that those decisions are documented as to why we made these decisions at this time, so that when we look back on this time, we know what we did and why. All of these charities and many more have come together as a group called One Cancer Voice to provide some guidelines for cancer patients, and it's a really good thing to signpost your patients towards if they've got queries about all of the uncertainties that are happening at the moment. This is a great resource for them. In terms of things for us, both NHS England and the Royal College of Radiologists have got fantastic amounts of resources about what we're doing, what the evidence behind some of our decisions are, so they're good things if you're interested to go and have a look at. So, in summary, in terms of when you're generally approaching oncology patients, a really good thing to think about and to talk, to let us know if you're phoning us for advice is what is the aim of treatment for that patient? Are they being treated palliatively or radically? If you suspect neutropenic sepsis, give them broad-spectrum antibiotics within an hour. If you think they've got cord compression, give them a big dose of steroids, 16 milligrams of Dex, and arrange a whole spine MRI. If they're on immunotherapy, really it's immunotherapy toxicity until proven otherwise, regardless of what symptom they come in with. So call us early, and we can help tease that apart. Most cases of SVC obstruction we would stent. If they come in with hypercalcemia, they need fluids and bisphosphonates. And my regular call is please contact the acute oncology service. We are here. We may not be visible very much in general medical wards, but we are absolutely here and very much want to give advice and get patients over to us as much as we can, but especially in the COVID-19 era when everything's just so much more nuanced. Please give us a call. We are absolutely here to help. And that's it.
Thank you, that was brilliant. I really liked that you included the clinical updates at the end of each section, so thank you for putting those in. We've had quite a few questions coming through, would you be okay to answer some of those?
Of course, yeah.
So the first ones were about spinal cord compression. What analgesia would you recommend at starting with?
So just your normal kind of WHO analgesic ladder, but if patients are in pain in general, they often require opiates, but give them some paracetamol always, even if you're giving opiates, paracetamol, codeine, and then Oromorph. Just be aware that patients may, if they've got widespread metastatic disease, they may already be on morphine. So if they're already on long-term morphine, consider increasing their dose of Oromorph. Encourage them to use the Oromorph as much as needed, and then over sort of 24 hours, think about whether you need to up their dose of long-acting morphine. But remember that if they get treatment, you might need to de-escalate quite quickly.
So regular reassessment and monitoring.
Exactly, yeah.
And then would you treat cauda equina in the same way?
Yeah, absolutely the same way.
Sure. And then a doctor in London is describing kind of having experiences of difficulties knowing the referral pathway for spinal cord compression. It leads to delays and then more limited options for treatment. Who would you recommend that's contacting from the general medical team if we're working there or in GP?
So there will always be a clinical oncology registrar on call. Sometimes in smaller centres, it'll just be an oncology registrar. In places like London, they often have a medical oncology and a clinical oncology rota. So clinical oncology, we give radiotherapy, medical, they give chemotherapy. So ask to speak to the clinical oncology registrar on call. Try and advocate for having an electronic system. We have a fantastic electronic system where you can just stick in all the patient details. It comes straight to us 24/7, and then we can liaise with spinal surgeons. But yeah, the first point of call, clinical oncology, and always phone us. We are often on call from home overnight, but just phone us.
Great, thank you. And then some questions about immunotherapy toxicity. What dose of prednisolone would you give at the beginning?
So it really depends on how severe, but we give either between 1 and 2 milligrams per kilogram of prednisolone usually.
Yes. And then a question about SVC obstruction. Would you always give oxygen, or would you titrate it depending on SATs?
Yeah, absolutely. Titrate it according to their SATs. Sometimes you can use it symptomatically, but yeah, you don't often need it unless their SATs are low. Often these patients have lung cancer, they've often got smoking-related lung disease, so they may be someone that you kind of tolerate a lower level, but yet, you know, titrate it.
And then we've got one last question, which are there any indicators that a patient would develop refractory hypoglycemia after bisphosphonate treatment? When we're thinking about malignant hypercalcemia, is there a role for vitamin D levels?
No, we don't tend to. So there doesn't tend to be anybody. Often, if it's like a slightly lower calcium, if you're treating 3.2 versus 4, it may drop further down. But no, there's no indicators. It's useful. It's sometimes useful to check vitamin D. We don't tend to in the acute setting. It's just one of those things to monitor. So if I treat someone with hypercalcemia and they go home, I tend to repeat their bloods with the GP in 2 days and in a week.
Well, Well, thank you. I think that's for this evening, and really appreciate you coming here this evening to talk to us. It's been so helpful on an important topic.
Brilliant. Thanks very much for inviting me, and thanks everyone for staying.